It's really nice to be here, and I am always happy to come to a place where I see students or former students, and Katrina Ortblad is one of the students that I worked with at Dartmouth, and Ben Campbell, who maybe some of you know, was also one of my students at Dartmouth. So I'd also just like to thank Victoria and Dane, and also Pete, who helped me get here today. I really appreciate it. And also I've liked the different social media tags that have gone out about this talk. They've been kind of funny. I come from stodgy New England, so it's nice to hear those jokes. Originally from California, but now in stodgy New England. I thought that, there we go. I thought that what I'd start out by doing is talking actually a little bit for about 10 minutes or so about my own personal and professional trajectory, basically what got me to this study that I'll then talk about more, in part because I know that a lot of you are students and you may be wondering where you're going and how you might get there with respect to global health work. So that's what I'll plan on doing. So for inspirations and trajectories, you might be wondering why you're seeing a picture of a horse. Well, in part it's because really my work as a medical anthropologist and my work in Nepal began because I went there as a study abroad student when I was 19 in college, and was raised riding horses and got interested in this question of how people in high mountain communities in Nepal took care of their animals because their animals were so central to their livelihood and their own health. And that led me, this is a picture from me at that time, that led me not only to write a book about that experience and about kind of coming into being an anthropologist, and also a reflection on this place, Mustang, Nepal, that I'll be talking about today, at a moment of a lot of generational change. But it was also really my first major foray into the discipline of anthropology and to what it means to do fieldwork, and now long-term fieldwork in a place. And so by way of that introduction, it's also really important that you have at least a little bit of sense of the place. And these are pictures from Mustang that give you a sense of this high altitude Himalayan terrain along river valley, the Kali Gandaki, along which trade and culture and lots of other things have been circulating for centuries. I was also and remain really interested in how communities of people have figured out not only how to survive in a landscape like this, but also how to thrive. And that has included trying to understand a lot about the medical systems in play in indigenous ways in these communities. But this is also a personal commitment. I've been going to Nepal now for more than 20 years. People that knew me as a relative kid, an unmarried 19-year-old, now know me as a mom. This is me bringing my then not yet 4-year-old, she's now 9, daughter back to Nepal to meet with friends and really people I consider family in the course of my life and work. Most of my work in anthropology as an anthropologist has ended up circulating around global health, and yet I didn't, again, necessarily start out thinking that was where I was going to go. But when it comes to global health, I think I get most interested in questions that in a way could be explored through this slide. This is a picture of a Tibetan doctor I've worked with for many years who, by his clothes, you might also notice he's a monk, he's a Tibetan monastic, and he is administering this picture a form of biomedicine. He's administering an IV of glucose saline to his ailing mother in a village home in Mustang, Nepal. And this slide, in a sense, illustrates all of these really fascinating questions about the human condition and about what it means to be ill and what you do when you are. Questions about medical pluralism, questions about resource scarcity, and questions about the kinds of creative and pragmatic solutions that people come up to in places like northern Nepal, where you often don't have a lot to work with when it comes to healthcare. I'm also really interested in medicines and in practitioners and practitioners' experiences. The picture on the left there is of the person that was pictured with me at 19 as well. Tampa Nawang is his name, and he's a doctor I've been working with now for more than 20 years in his clinic. And then on the right, there's a sort of snapshot of what rudimentary healthcare looks like in a lot of rural Nepal. This is the a local dispensary, stocked actually quite well because the shipment just got up there, but come a couple of months from now or even a couple of weeks from now, and there'll be a lot less on those shelves. So interested in these dynamics of how medicines circulate and how people make choices also about what kind of health care they're going to seek. These are remote places, and then therefore part of what I'm interested in is how people make choices to either get health care in these remote places or travel out of them for health care, and the kinds of cultural and social barriers that come perhaps when a laboring woman enters a space like you see in this cutout picture, and or when people have to make a decision. Do I try to give birth in a space like that, or do I give birth at home? I've been working with a group of Tibetan medical practitioners in Nepal through an organization that they founded and that they run for many, many years. And with this work, I'm really interested specifically in the ways that a traditional form of practice and of knowledge production and transmission between generations is sustained and also transformed in the 20th century. In other words, what does it mean to be a traditional practitioner in the modern world? My work with doctors led me in different ways to being interested in women and women's health, and I've spent a lot of time working with women. You'll hear a little bit about how and why in the project I'll describe later. But I've also been involved in an NGO called One Heart Worldwide, which began in Tibet, in the Tibet Autonomous Region, and has come now to work in the state of Chihuahua in Mexico, in the Copper Canyon area, primarily with Tarahumara or Raramui indigenous communities, and also in a lot of places in Nepal. Through my discussions and work with women and on women's health issues, both in Nepal and in Tibetan areas in China, I began to get really interested in how ideas about pregnancy and childbirth and practices around where people were giving birth and why were changing as a result of generational shifts and also migration. And so in the picture that you see here, you might not think this, but it's interesting to know that the little baby next to my daughter in my friend Pema's hands was born in Hoboken, New Jersey. And is now back living in Nepal. And the girl grabbing onto her mother's neck was born in the home on whose roof we're standing in this picture in northern Nepal. So the ways that wage labor migration, possibilities for moving across spaces of citizenship between being Tibetan, being Nepali, and coming to a place like America influence reproductive histories and the changing shape of the populations. I've also been really, really interested in, and my next big research project will probably focus on this issue of migration and to a certain extent how it relates to health. The Viva la Revolucion there on the right is an old Tibetan guerrilla fighter who lives in a northern village in Mustang. And the transformer there, that's what the shirt says, he's wearing a Transformers shirt with his Paris Hilton shades, is a new generation of Mustangi American who is was born and is being raised in Queens. So I want to give you a little bit of framing, too, for the kinds of questions that a lot of my research has asked in relation to global health, and specifically to highlight some of the method, as I put it here, methodological, ethical, and cultural conundrums that this produces. I've spent a lot of time thinking and working with traditional Tibetan doctors about not just the plants and animals on which their pharmacology depends and how they are becoming critically endangered, but actually how the knowledge that these doctors possess is becoming an endangered species, if you will. And that has to do with a lot of different social and economic changes. This has brought me to do a lot of collaborative ethnography, and by that I mean not just working with other anthropologists or physicians or public health experts, but also collaborative in the sense of letting doctors like this shape a research agenda. I've also spent a fair amount of time thinking about the relationship between ecology and environment and medicine for a lot of different reasons, but in part because, again, the plants and animals and mineral products on which these doctors' healing repertoire depends are being radically changed, again, by diverse issues from overharvesting for commercial production of traditional medicine to climate change, because, of course, we're talking about the roof of the world, the third pole. This leads me to another area of my research, and that is what I'm calling here high science on the roof of the world, thinking about the ways that practices like the structure of an IRB or a randomized control trial translate to places like Tibet. For 2 years, from 2002 to 2004, overlapping with my dissertation research, I participated in the first randomized controlled trial to take place in Tibet. I also helped to form Tibet's first IRB. And this project focused in and around the issue of maternal mortality and especially postpartum hemorrhage. And that involved a whole set of ethnographic work for 2 years to try to come up with an informed consent protocol that actually would make sense and truly be ethical in a local setting for Tibetan women. And to literally and figuratively transform a traditional medicine called Shishe Chukchik, which you see on the right here, into a new form that could be compared to a placebo, and then also was a two-arm trial compared with misoprostol or Cytotec, which is a drug that's used to control postpartum hemorrhage. And that and these other projects lead to really interesting questions that drive a lot of my work, questions about translation, about evidence, and about efficacy. And I know that these are issues that you guys deal with in your work all the time, but in perhaps different ways. For instance, you might not think about the ritual efficacy and the importance of doing a medicine empowerment ceremony for the placebos in a clinical trial such that any medicine that might be given will still have a beneficial effect for sentient beings. This is not the way we think about a placebo, but this is how Tibetans that I worked with think about a placebo. I've also been interested, again, in sort of the other spectrum, from the small-scale producers to the scaling up of industry around Tibetan medicine. And this has taken the form of studying large factories and the production regulations around Tibetan medicines, both in the US and in China. And then finally, I've turned toward patients and done a fair amount of work on illness narratives and what it means to be ill and to seek care in places like Highland Nepal or Tibetan areas of China. And that's taken me not only to places like this. This is my research, one research assistant I've worked with talking to a village woman in Qinghai province, or to a hospital of Tibetan medicine in the capital of Qinghai, Xining, but also to the much more rural and much more tactile realities of Highland Himalayan healthcare. So now to sort of the bulk of what I want to share with you today. And I will vacillate a little bit between talking and reading, just to let you know. Anthropologists are notoriously bad at reading their talks and putting everybody to sleep, and I'm going to try not to do that, but I will read a little bit. So this project developed basically out of long-term field work that I'd done in Mustang, and in some ways a shifting focus in my work from spending a lot of time with old men, those old Tibetan doctors, to spending more time with younger women of reproductive age. And then also to thinking about these larger patterns of social and demographic and epidemiological change. And with this project came new challenges, such as the ones that I was describing before, challenges about methodology, about ethics, and about what research collaboration is all about. So these are some of the things that I want to talk about today. And I'm going to start, like often ethnographers do, with a story, with a vignette. You want to take my spit all the way to America? A woman in her late 50s from Mustang, Nepal, looks at a small plastic tube in her hand. My research assistant and I affirm this seemingly bizarre request, describing for the 8th time today why we would like to collect this specimen of herself, and why we would also like to ask her about her pregnancies and her birth experiences, her household, and her network of kin. We explain that culturally Tibetan people have special abilities in their bodies to live and be strong at altitude, that this specialness can be seen in their gyu, a term that literally means lineage or continuum, but that also links to kinship and serves in this instance as a vernacular gloss for genetic inheritance. We follow a script that was initially written in English, then translated for IRB purposes into Nepali, and that we are now reciting in a local Tibetan dialect. This specialness in the bodies of people living in high-altitude regions like Mustang, we explain, may also be related to how many children women have and how many survive. We've reassured this woman from Mustang that we do not want to take any of her blood, but that if we can take some of her spit back to America and test it there, we can learn more about these issues and perhaps produce some knowledge that might be useful for the health of future generations. We explain that we will also measure a few things with a machine that fits on her finger. We tell her this won't hurt, but that it'll tell us something about her breathing and if she has some weakness in her blood, which is a signal here for anemia. If she agrees, we need her signature or a thumbprint if she can't read on a piece of paper. Would you be willing to give us the spit and answer some questions? My research assistant asks. This woman, who I'll call Lamo, takes in this information while squatting in the sunny courtyard of her high mountain home. This isn't Lamo, but this is an illustration sort of like that. We've caught her as she's come back from weeding her buckwheat fields. Her hands are calloused and she has arthritic-looking knuckles. Lamo holds the plastic spit kit we have given her with a gentleness that one might reserve for a wildflower. During our explanation, she nods in agreement when we say that people like her are uniquely suited to living in this high-altitude environment. She consents to participate in our study, and since she's not literate, she does use her thumbprint. Then, still holding the spit kit, she looks me in the eye, and she says, "My children are in America, and now my spit will go too, but this old ama, this old mom, will stay here in this village doing all the work." Lamo has a good sense of humor, and she moves with grace despite her years of physical and reproductive labor in Mustang. Hers is one story of hundreds in this biocultural expedition through women's lives in highland Nepal. So I'll tell you a little bit about the research in question, and there's some details on the slides, and I'll speak some other information. So as you all know, perhaps better than I do, fertility and child survivorship emerge not only from direct influences such as marital history and whether or not people use contraception, miscarriages, abortions, as well as genetic inheritance, but also from indirect influences such as socioeconomic status, education, and social ecological factors, including, in this case, altitude. At each turn, these biological events are inflected with meaning. They're understood culturally. As anthropologists remind, the documentation of biocultural patterning of reproductive practices across cultures is a really rich empirical and theoretical terrain for understanding social and biological reproduction within specific political and economic contexts, as well as helping us to understand in a little bit more nuanced terms what this odd but somehow still descriptive idea of reproductive fitness actually means. So this is the research team, and we aim to explore this research. We know that on the one hand, this project is rooted in biological anthropology, in part because the PI, Cynthia Bell, is a biological anthropologist who spent the better part of 30 years studying how Tibetans in particular, but also Andean populations, have adapted to living at high altitude. But the project not only includes me, a medical and cultural anthropologist, but also Jeff Childs, who's a demographer, as well as a cultural anthropologist. And you'll see some of his demography at work here, and I take no credit for that. I am not trained in demography. Yet, even though we have the three of us, none of this could have been done without our cross-cultural and collaborative research team, which included a bunch of young women and some young men from Mustang and also from the areas of Nupri and Sum in northern Gorkha district where we did this work. And here's a map to kind of locate us. So this is Nepal. The part of the country that I'll be talking most about today in terms of the images I'm showing you is Mustang, the orange one, and then Gorkha district, northern Gorkha district, is in blue there, and the areas in Gorkha are called Nupri and Sum. So you'll hear me using those terms throughout the talk. These are parts of Nepal that are culturally Tibetan, by which I mean people practice forms of Tibetan Buddhism and other aspects of Tibetan religion. They speak dialects of Tibetan. And they've engaged for decades and generations in trans-Himalayan trade. And also they share, I would say, experiences of, in different ways, socioeconomic, political and infrastructural marginalization in the case of the nation-state of Nepal. So Nupri and Sum, there are some road projects that are just getting started there. By road, I mean motorable road. Mustang now has a motorable road, but it's one of the scariest roads you ever will go on. These are places that are not easy to reach and that have been neglected in different ways by the Nepali government. Here is a picture of Nupri and Sum. So our methods, how do we do this project? We used interviews, we used surveys, and also kinship charts. So we drew elaborate kinship charts of each of the women's network of family. We also used non-invasive biometric data collection tools like this one to measure things like oxygen saturation and hemoglobin levels. And then, of course, we collected saliva samples for DNA analysis. So specifically, this is what we gathered. We ended up interviewing more than 1,000 women, which I know is a tiny N for you guys, but for up in northern Nepal, it's a lot. And we also, we actually gathered data from about 5,000 individuals because we did a big household survey as well. I also spent a fair amount of time doing qualitative ethnographic interviews with a small subset of women, an N of 30 there, both women in our study and then women who were of a younger generation, people who were 39 and under, about a whole range of things to do with what they think about and know about issues of reproduction and fertility. Oh, and I will say one other thing. Right now, the million-dollar question about whether or not this hypothesis that we have about women that have these genetic markers having better reproductive outcomes is still a question. We're in the midst of doing that genetic analysis. But in practice, of course, all of these methods for data collection meant sitting for many, many hours a day with mothers and grandmothers, listening to them recount stories of births that went well or not, of neonates who died for no reason, just sort of women throwing up their hands saying, I have no idea, children who succumbed to accidents, to diarrhea, to attacks by ghosts or nefarious spirits called nupa in Tibetan, or to infectious disease. So gathering this reproductive history work involves several methodological challenges and highlighted in different ways than some of the work I did in Tibet on the IRB and this clinical trial, how what Arthur Kleinman calls everyday moral worlds can come to kind of conflict with, in a strict research ethics sense or bioethical sense, what ethics means. And I'm going to give you two examples. So the first is about gaps. Part of our strategy as interviewers was to ask follow-up questions when there was, in the reproductive history intake, more than 3 years of a gap between pregnancies. And so as an example, we ended up doing this for 65% of the total of 819 women that we interviewed in Mustang. And as a result of this methodological practice, we added 140 live births to the records of 88 women, and also 22 stillbirths. So this information ended up adding about 10%, a little more than 10%, of data on the individuals interviewed in Mustang. In other words, the probing was really important from a methodological perspective, but it wasn't always comfortable. Sometimes probing for gaps meant revisiting someone's marital history and realizing that a pregnancy that actually led to the birth of an illegitimate child, a nyelu or a nyemo, often a source of embarrassment or a kind of public secret in these communities. And although we really tried to collect data in private homes or in segregated spaces within schools or community halls, there were limits to the degrees of confidentiality that we could guarantee. Probing for gaps could also link to contraception use, which in some cases people felt good about, in other cases people were really shy about because there's still a kind of moral disparagement around the use of contraception among women of a certain age. Or it could simply uncover a forgotten or buried painful memory about a loss. And at other times we struggled with elderly women simply for them to remember, right? Which one was that way back then, and what season, and all of this. because of course mental acuity and age compromises recall. Yet in such moments, interviewees often would turn to a daughter or to a daughter-in-law, to other village women to help them. And in such cases, what started out as one woman's individual interview became a collective exercise in remembering. And while such moments ensured greater accuracy of the data itself, it also revealed tensions between a strict bioethical paradigm that relies on a more individual sense or framework for consent and confidentiality issues, and one that emerges from a more sociocentric idea about personhood and the practical and expected, in a way, limits of privacy within and between kin groups in a village setting, right? Privacy is just not there very much in the way that we tend to think about it. The other example I'll give is about speaking of death. Tibetan cultural taboos against speaking the names of the dead often came up in our interviews. And we could usually kind of work around it. We could get the name of a deceased teenager, for instance, or a spouse by piecing it together from other relatives, or asking around the question in a sense if we needed to. And for infants who died either in the first moments of life or within the first few weeks, normally aren't named anyway, because that's also part of Tibetan tradition. Naming doesn't usually take place for at least a week. Getting at the names of kids who maybe died before they were 5 but lived for a couple of years was often tricky. And in such cases, we really had to, and in some cases, we would ask about a child who died later in life, and it would provoke this horrible story of a road accident or someone getting murdered on a trading trip to India. So it would bring up a lot of stuff just by virtue of these very relatively simple probes. And so we had to weigh, in other words, getting accurate information with the relative level of distress that women would experience in going there, essentially, in their interviews. And interestingly, and this resonates also with the project that I did in Tibet, for some interviewees, simply the act of speaking about such things, about such bad outcomes, or about such death in the past, was interpreted as inauspicious and an action that in psychosocial terms could not just disquiet somebody's sem, their heart mind, but also set into motion possible future negative events. And again, this is just a different way of thinking about the relationship between cause and effect. And it's important, as anthropologists always try to remind, to be culturally relative about this, that the way that we think about asking relatively innocuous questions are not always innocuous. So demographic and epidemiological indicators like total fertility rates or maternal, infant, and child mortality ratios in Nepal and China, the kinds of big data that all of you work so well with, remains really useful, of course, in conceptualizing all sorts of broad social and economic change and public health challenges. And again, this is, I'm speaking to not the converted, the leaders here on this. And yet, at the same time, we can sort of couple that or learn different things by looking ethnographically at things. In places as diverse as India, Brazil, Guatemala, and among Tibetan cultural communities, there have been really good ethnographies about birth and loss in early life and maternal and child death. These perspectives bring to us a whole different way of seeing the world, right? And these dynamics tend to privilege affect, privilege understandings of what Michel Foucault and others call biopolitics, and the dynamics of reproduction over more or differently empirical forms of documenting population change, the kind that IHME is so good at. In the case, it's important to remember, though, in the case of Tibetan communities in particular, geopolitics also shapes what we can know in demographic and epidemiological terms. This isn't simply because working in Tibetan areas in China, for instance, is hard, but that is the case. It's also because so much of the aggregate data from which, let's say, national census or demographic health surveys generate for a place like Nepal, they really remain blunt instruments in the case of communities like we were working with, in great part because culturally Tibetan people, whether in China or in Nepal or even in parts of India, are situated as minority ethnic groups or minority nationalities within multi-ethnic states dominated by other ethnicities or castes, both, and I say dominated not just in a political sense, but also in a demographic sense. So getting at where these people fit onto these larger scale instruments, they kind of disappear a lot of the time. And you might also think that, you know, two high mountain communities speak Tibetan, have similar lifestyles, that they're going to be pretty similar, but actually they're very different. And so how are they different? Well, here are some patterns. And I'm going to return to the issue of fertility decline toward the end of the talk, but one of the more striking results of our data revolved around parallel trends toward outmigration, especially among young people, but quite different overall fertility trends between these two communities. And so just to help navigate this, the light shaded areas basically indicate people who belong to households in these two communities, but who don't live in the village, right? So you can see a huge amount of people who are out. Well, the age-sex composition in Nupri and Sum reveals a relatively young and growing population experiencing still relatively high fertility. Parallel data from Mustang shows a population in which fertility transition has been underway probably for about 2 decades, and where there are really distinct patterns and reasons and expectations even for outmigration. So to go deeper into this, here you see the population projections for Mustang under different migration scenarios, and you can see sort of where this is going, right? The lowest one being outmigration only, and the others relative rates of return. And this then leads us to some of the demographic impacts. You see this convergence of the very old and the very young. And here's an illustration of the social impacts of a population in which the elderly and the very young continue to converge, raising serious questions about the long-term viability of these high mountain communities. Our data also told us a lot about marriage and different approaches to marriage. Both of the spaces in which we were working practice forms of fraternal polyandry, and I don't mean this to be an Anthro 101 kinship lecture. That means that a woman marries brothers, more than one man, usually brothers, as well as forms of cross-cousin marriage, as opposed to parallel cousins, and these are and other strategies for where a woman lives once she's married, and whether she stays in her house or she goes to the man's house. What we learned in our study is that roughly 20 to 30% of all the women in the study were widowed, which is a pretty high number. Virtually none were currently divorced, and between 7 and 14% had married their cross cousins. Polyandrous marriages accounted for between 5 and 15% in these different regions, higher in Nupri and in Upper Mustang, which has, I think, a little bit to do with the fact that these are, Upper Mustang is still a kingdom. It has to do with sort of relative social hierarchies in these two places, and both of these strategies are ways of maintaining wealth within a larger household and land within a larger household. So anyway, again, I don't want to go too far into kinship because you'll go to sleep. But another really interesting finding here was that you might expect that at this point in history, or as people kind of transition to different forms of what marriage is about, that you'd have more love marriages and less polyandry. And part of what we found is actually in second marriages. So if usually a woman was widowed, in Upper Mustang especially, they were equally likely to choose a polyandrous marriage over as they were to choose a love marriage for their second option, which is, again, kind of an interesting take on or a challenge to the idea that somehow you start out traditional and then you get modern, right? The world doesn't really work that way. So all that being said, more women in Nupri and Sum were married, and there were a lot more nuns. The red bars are nuns in Nupri and Sum, and the blue in Mustang. When we focused on women just residing full-time in their districts, more Nupri women were or had been married as well. And so here's another snapshot. Oh, for some reason, the shift from a Mac to a PC messed that up. But basically it says that fully married women were basically people who were married before the age of 25 and who remained married until, with that husband until they were at least 40, so sort of through the arc of most of their reproductive, highest reproductive years, or who, if they were widowed or divorced, got married within 2 years again. Here we go. In both field sites, the women were on average 55 years old and had their first pregnancies at the same average age of about 24 years, even though women from Gorkha tended to marry about 2 years earlier than those from Mustang and were more likely to become pregnant for the first time after marriage. In the interest of time, I'm going to skip a little bit of this. This is the distribution of stillbirths and miscarriages, and just the main thing to note is that a little more than 11% reported from 1 to 6 stillbirths. Again, 1 to 6. Imagine having 6 stillbirths. And 12.7% reported from 1 to 3 miscarriages. But miscarriages, as many of you probably know, are really difficult things to wrap your heads around because sometimes they happen and women don't even know that is what has occurred. So now moving on to child survivorship and child death. Notably, a lot of the women in our study didn't report any infant death, even though long-term fieldwork in these areas makes it clear that infant and child mortality remains a relatively common occurrence and that access to basic OBGYN care is a challenge for a whole range of economic and social reasons. That said, there's still a lot of richness in what we were able to gather. We were also cognizant of the impacts that age of marriage and first pregnancy can have on infant and child survival, as well as the possible impacts of pregnancy and birth order on survivorship outcomes. And part of what we learned is illustrated here, that basically young mothers younger than 25 and those 45 and above have lower infant and child survivorship, and that pregnancies 9 and 10 are associated specifically with lower survivorship. And this table shows some details of that. And if we were to extrapolate out in the way that my demographer colleague Jeff can do, some of this data to think about IMR, infant mortality rates, you would see an IMR for moms under 25 of about 190 deaths per 1,000, compared to moms in their 30s, essentially, or 30s to mid-40s at 130 deaths per 1,000. But here, again, if you look at the big data, the national IMR for Nepal in 1990 was 90 per 100,000. And in 2011, it had dropped down officially, according to UNICEF numbers, or no, sorry, excuse me, to CIA numbers, to 42. So you have drastic differences, right, in the kinds of information that you get from the kind of data that we were gathering and what's available at a more aggregate level. Here, there weren't so many associations between pregnancy order and survivorship. The pattern is not that clear, but you can see that number 2 and number 6 and 7 do worse than 3 and 4 and 1. So here we see depictions of the number of live births of children surviving to age 5, and an overview of the number of child deaths reported by women in our study. So in this, perinatal, neonatal, infant, and child unspecified, in other words, women throwing up their hands and saying, I don't know, they just died, are the leading cause in both places. But notably, actually interesting, breathing and talking about the difficulty of breathing, so birth asphyxia in one way or another, was the leading cause reported by women in the first 24 hours. Other causes of death also shifted between what we would recognize as causes, in other words, biophysical causes like not being able to nurse or diarrhea, and Tibetan-specific causes that had to do with spirit attacks, that had to do with forms of spiritual pollution. And this, again, is important to recognize. So that while an unspecified or no reason or unknown answer accounted for the majority of child deaths in both districts overall, as shown here, So this is child deaths in Gorkha, and I'll talk to you about measles in a second. But you see, measles and Tibetan-specific causes are right up there. And here is the data for Mustang. You have this interesting balance, right, between causes that are uniquely cultural, in a sense, and causes that are much more broad or more biomedical in orientation. So now I'm going to talk a bit about fertility decline. Oh, sorry, I do want to mention one other thing here. As I talk to women about what they make of death, right, how they understood these experiences, all women cited spiritual problems as primary causes, even if the thing that they then said was, oh yes, and it was about breathing, right? So for many, such events were literally, they say, written on the forehead. They're the results of karmic action. While in other cases, events could be attributed to astrology or spirit attacks. And so the important take-home here is that idea, that kind of meta reason for the reason, is embedded in a cultural framework and a moral framework that emerges from this place that's about Buddhism. But that doesn't mean that the women are not saying, yeah, and hygiene's important, and access to healthcare is important, or falling down, or any of these things, material causes isn't also there. These things are not mutually exclusive. So fertility decline. Historically, Tibetans have regulated their fertility in a range of ways through having high numbers of monastics, for instance, and a relatively high infant and child mortality. But in addition, in recent years, Tibetans have managed their households in a range of other ways. Historically and today, they do this through postnatal adoption, through marital migration, monasticism, all of these things. And today, one of the best ways to sort of navigate fertility is actually about education. People from these communities in Nepal began to become aware of new opportunities essentially to manage their family size and composition, principally by sending their kids away to boarding school, where they would receive lay or monastic education. And as alluded to before, but especially acute in Mustang, these patterns of birth rate and fertility decline have these major ongoing implications for these communities. And specific to our research, it actually, when we started to see the magnitude of this issue, it started to really drive home the fact that, wow, we were lucky to do this research when we did on the group of women over 40 when we did, because these are women, perhaps in some cases the last of their kind, who will be having 4, 5, 6 or more children or pregnancies, and who are still spending most of their time living at altitude. But also, since I'm showing a picture of condoms here, it's worth talking a little bit about fertility decline in relation to contraception. Condoms are not the birth control of choice. Kids use them for water balloons primarily, but they're still a signal, if you will, to contraception. In Gorkha, in Nupri and Sum, modern birth control is a relatively new phenomenon. And in our survey, only about 22% of women from 40 to 54 had ever used contraception, and only after giving birth to 4 or more kids. And so this may be contributed to the decline in total fertility rate. It's not being used at sufficient levels to commence a sustained fertility decline. But in contrast, in women in Mustang, 58.2% of women in that same age bracket have been using contraception, mostly Norplant and Depo-Provera, which raises a whole other set of issues around women's health. So let's look at some of the trends. In the case of Nupri and Sum, as well as women in the villages, as well as people from Nupri and Sum living in other places, the trend is downward, albeit a little bit more slightly. This is Mustang, much more dramatic, right? And then when we start to look at age-specific fertility rates in Mustang, you see this sharp drop, which is probably indicative of the introduction of more contraceptive use there. And this has also happened, that there's been a decline at all ages since about 1997, both because of all of these dynamics, really. And furthermore, shifts in fertility and child survivorship are linked in some pretty interesting ways to the limited and variable yet undeniable improvements in healthcare delivery within these communities over the past two decades. And so this not only means the extension of contraceptives to the village and the making of local women into what anthropologist Stacy Pigg calls contraceptible bodies through state and NGO development efforts, but also the success of childhood vaccination campaigns. Remember those measles spikes? Well, that's not occurring anymore. As well as state and NGO projects. But again, interestingly, in Nupri and Soom, most of this has come from NGOs. Well, in Mustang, there's a little bit more of a balance between NGO support and governmental support for healthcare. And this is also impacted by people going out of these areas having remittance money to send back to help people support their healthcare needs. And this has been changing people's ideas about what is good healthcare and where you get good healthcare and why you might get a C-section in a hospital and on and on and on. And all of this is in a context where, again, women would talk about these issues of spirits on the one hand, of basic health and hygiene on the other, and on what Paul Farmer and others would call upstream causes of fertility transition or social and health changes to do with things like economics and forms of structural violence. They are very cognizant of these things, but see them, again, as not mutually exclusive. So I know that we're getting close to the end here, and I want to wrap up again with a little bit of ethnography, because a major goal of my work and other anthropologists is to try to understand life, not just from the big data perspective, but in more granular terms. So I turn to some field notes. At 47, Wang Mo has been married twice, the first time at age 28, the second when she was 43. She's had 3 sons, 2 with her first husband, who she divorced at 35, and a third through a socially unrecognized partnership. Her 2 eldest children are both monks. Her youngest son is in boarding school in Kathmandu. After abuse and interpersonal difficulty in her first marriage, she's now in a marriage of love and mutual understanding with a man several years her younger with whom she has no children. My husband is kind to me, she says, but I don't know the future as I cannot enter into his heart. Don't we all know that is true? On birth control, she's had 1 Depo-Provera injection after her divorce, but that wore off, and her Nielo, her illegitimate son, was born when she was 36. She's still menstruating. She doesn't use birth control, but she hasn't been pregnant either. She received health care during her pregnancies, but only in Benares, India, where she went to engage in winter petty trade. All 3 of her children were born at home without any SBA, so to speak, skilled birth attendant, but with female relatives in attendance. I cut the cord of all 3 kids by myself. Wang Mo had 3 live births, no miscarriages to her knowledge, and all 3 children are alive today. She views miscarriage and stillbirths as the result of karma of the woman to whom it happens, or as the result of not taking proper care to eat good food, to stay warm, to not work hard, and to stay clean. Infertility, she explains, comes from the reproductive essence of a man and a woman not being compatible. If an infant or child dies, one must take care to bury the body in the astrologically correct direction. If not, then the next child will also die. I've seen this, she says. Women and infants die when deliveries are difficult or so painful, but this is also the result of karma and your previous life. On her conception of ideal family size and fertility transition, she says, in the past, women would give birth to as many as 10 or more children, but these days, people stop doing this. The economic costs of raising children and sending them to school is, for her, much more of a convincing explanatory model than increased access to contraception or access to even biomedical health care or women's education, all of which we know impacts fertility. But she mentions all of these dynamics. She then talks about fellow villagers choosing to give birth abroad or to send their children to live with relatives in New York as an economic blessing but a social hardship. She says, I have 3 sons and that's enough, but I wish I had a daughter also to take care of me when I'm old. The more children we have, the more kinship will flourish. But now it seems like all kinship is ending. So to wrap up here. When I set out to do this project with a biological anthropologist, I was pretty skeptical of the premise that reproductive outcomes could be neatly explained in genetic terms. It was not an explanatory model that I was very used to. Too many other confounding factors and explanations got in the way of me seeing the reproductive stories of someone like Apu here on the left, who was our only married research assistant. She was pregnant with her first child when we did field work. And she had a 10th grade education with the EB, the grandma there on the right. She had 8 pregnancies, 4 living children, a dead husband, and no education. And she obviously is taking care of a grandkid. But over time and the process of these hundreds of interviews, I began opening up to genetic possibilities as filtered through high-altitude living as a meaningful causal frame. The answer, though, remains to be seen. We don't know the genetic analysis yet. But as we turn to the writing up of the results of this research, our biocultural expedition has called me back to themes that run through my other work, namely translation, evidence, and efficacy. Translation in the sense between biological and cultural ways of knowing the body and what Margaret Locke calls local biologies, understood here both with respect to adaptation to altitude, but also to karmic and socioeconomic understandings of what happens to biology. And so I'm left contemplating what is lost and gained in the translation between genetics, for instance, and youth. Evidence is not about whether medicine works or not, as in my other work, but rather what causes infant and child death in highland Nepal, and how do we make sense of the different forms of evidence that we're presented with about why. And finally, efficacy in terms of what has worked to sustain these communities over the long term, both biologically and culturally. What does primary health care or access to contraception have to do with this? And what will happen as the impacts of depopulation and social change, including the major social and biological transition to no longer living at altitude, but living instead in Queens or Kathmandu, settles in. Thanks. Question? Yeah.
So, what's the perception of Western medicine? And I'm curious if they had in these communities any implanted NGOs or physicians, like in African countries I had no clue of.
Yeah, it's a big question. I think people generally, if I can make this big of a statement, they like Western medicine. It's just that they don't always have very good access to high quality Western medicine in their home villages. It's worse in one of the study sites than the other. There are NGOs working in these areas, and in some cases we even have documentation, I didn't go into this, of infant mortality rates dropping after an NGO-funded health post was set up in Nupri and Sum. But people have complex relationships to Western medicine. It's telling, right, that a woman will go and have a C-section in a hospital in Kathmandu or in Hoboken, New Jersey, but when she's at home and pregnant, she would much rather give birth at home and not go to the little health clinic, with one of those horrible little beds with the stirrups and a male attendant, or someone who doesn't speak her language as the interface for biomedicine. So this is a very interesting question. Our data for this project did not in a major way, but when I did my ethnographic interviews, absolutely, this is something that I explored. And among both cohorts, it has everything to do with location and a lot less to do with some firm ideology about, I like Western, no, I like traditional. It was about the fact that they would, if they were in their village, they would much rather give birth at home, and if they were not in their village, they would go to a hospital. Right? And yet that's happening at a time when, in many other parts of the world this is happening too. The government and multilateral organizations are incentivizing facility-based birth. In some cases, those facilities are pretty nice or getting better. The NGO that I work with is trying to build nice birth centers, for instance. But in some cases, they're centers that nobody would want to go to and they see as, a place of death, not a place of life. Yeah. Yes?
You were asking about deaths of children. You mentioned how hard it was to get that information. How did they feel? You said you also used information from daughters or aunts or something. How did they feel about asking a relative about that? How did you get around that?
They actually preferred that a lot of the time as opposed to voicing the thing themselves. And so it depended a little bit on how far along we were into, moving our way through a village and whether or not we could identify easily a sister-in-law or, somebody else to talk to. But Yeah, again, it's one of those things where our ideas about privacy or not telling is exactly the opposite logic. Like they would rather have that burden, if you will, be on somebody else to say that for them, than having to talk about it themselves.
So the taboo didn't, so if my sister's daughter
Yeah.
died, I could talk about it, but my sister couldn't?
In some ways, yes. It's not always that sharp, but it has to do, again, with cycles of karma and ideas about willing something into being by voicing it. So nupa, this term that is I glossed as ghost or nefarious spirit, it also means internal sort of mental musings that are harmful, and in a Buddhist philosophical sense, and that's sort of where the term comes from. So it's this idea of if you sit there and obsess about these things that have happened in the past that have been bad, they're maybe going to come out again, right? And I skipped a little bit of this, but in that last ethnographic portion, there was this nupa that was in the form of a grandfather that had been stealing a number of kids at a particular point in time and either having them die of measles, right? So you have this, spiritual cause that leads to a infectious disease outcome, or having kids drown. And so, anyway, it works in interesting collective ways. Yeah.
Hi, I also thought it was very interesting the discussion you had on sort of probing and how you drew out sort of these things that happened in the past. I was curious what other sort of methodological challenges you faced. Particularly curious about family planning practices. And
Yeah.
if that was a challenge, talking about that and what your strategies were.
Yeah, with women who were older, but not so old that they might not have used contraception at all, like women in their 60s and above pretty much wasn't there, and they didn't use it. But women in their 50s and their 40s, there were a lot of moral debates going on, and these also interesting things that would come up, like one woman, a number of people would explain, like, if I use contraception, then that's going to increase infant and maternal mortality because I'm blocking the womb door, which is how Tibetans think about conception. I'm blocking mine, and so even if I might be ready to have a kid, that soul or that being is going to go into somebody else's womb that's not ready, right, in the community, and that will create an infant death. So there are all these interesting moral discussions. So we had to whisper at certain points. We would have to kind of move to other quiet spaces. Or sometimes there were just quick slights in the language to indicate things. And other times people were really direct about it. They said, I've had too many kids. I didn't want any more kids. This is why I got my Norplant, and they were fine with saying that. Yeah, in the red in the back.
So you quickly said that you found really different infant mortality rates than in the national studies. And do you think that that's just because of some larger factors like economics or education that are really different across the different parts of the country, or some of these methodological changes or differences that you might have with the
I think probably both. I mean, in some ways, I trust our data more for these kinds of communities because I know how the NHS gets done in Nepal, and people don't go to these places. They're estimates of guesses of guesses. And at the same time, there are also these issues around, huge variation in Nepal around practices to do with pregnancy and childbirth, and yes, urban versus rural. But generally in these communities, women are getting married a little bit later and having a fewer pregnancies, at least for this age cohort that we were looking at, than women in other parts of Nepal, especially more Hindu Nepal. So, there are all sorts of reasons then to be skeptical about the national data for other reasons, right? Yeah.
You mentioned you work with some local people as well.
Yeah.
How did you find them and how did you engage them? Get them engaged?
Yeah, so this was actually a really fun part of the project because I got to call up all of my friends who have now young women who are daughters who are in their 20s who have exactly followed these patterns. They are not married, they do not have kids, they're getting PhDs or BAs in the city or in other places, and I was able to recruit them. And it was a really fantastic experience for them, actually, to go back and engage with their grandmas and their aunts in ways that they normally wouldn't get to, and to learn, you know, some social science in the process.
Are you working with them over course of years or just once every time?
So we created this field team specifically to do the field data collection in 2012. But but we've continued to work with them a bit, and I actually hope to work with some of them at least again this summer when I return to Nepal. And you know, yeah, I'm very curious in their trajectories too, you know, as examples of all of these issues. And for some of them, you know, they were completely naive about what pregnancy was about, what birth was about, you know, and then we had this surprise event of one of them discovering that she was pregnant on the trip, and that was, you know, a whole other interesting experience. So, yeah.